everyone. Good afternoon. Welcome to our Yale Sleep Medicine Grand Rounds. My name is Ritika Thapa, and I'm one of the Pulmonary Critical Care and Sleep Medicine faculties here at Yale. Just a few brief announcements before I introduce today's speaker. Please make sure that you're muted. In order to receive CME credit for attendance, please see the chat room for instructions. You need to sign up to get that credit. And if you have any questions or comments during the presentation, please use the chat room, or you can unmute yourself in the end and we'll moderate the session as well. And the recorded versions of these lectures will be available on YouTube a few weeks after the presentation. And now I have the pleasure of introducing Dr. Justin Fiala today. Dr. Justin Fiala is an assistant professor with dual appointment at Northwestern University's Feinberg School of Medicine and Shirley Ryan Ability Lab in Chicago, Illinois. He completed his residency training in internal medicine, including an additional year as chief resident at the Mayo Clinic in Rochester, and went on to complete his fellowship in pulmonary critical care and sleep medicine at Northwestern as well. His clinical interests include diseases of ventilatory control and chronic respiratory failure, with a focus on liberation from mechanical ventilation following spinal cord injury. He's also very involved in teaching activities and has received many teaching awards. He's also lectured in courses in sleep disorders nationally and has authored many publications. Dr. Fiala is also very passionate about sleep health equity and spends his free time running the CHI-PAP free sleep clinic, where he provides pro bono sleep-related evaluation and treatment for uninsured patients across Chicago, which is a huge task that he's undertaken. He's also a visual artist and has had his work showcased in multiple publications, including the Chicago Tribune, and has shown his paintings and sculptures at live events, including TEDx Chicago. Would love to see that someday. Thank you so much for being with us, Dr. Fiala. And without further delay, I would like to hand it over to you to share your expertise on tackling disparities in the diagnosis and treatment of sleep apnea, the CHI-PAP model.
Thank you so much, Dr. Thapa. And thank you so much to everybody at Yale for having me speak to you today. This is, again, something that I'm very passionate about. And so we'll start with a little bit of data behind sleep disparities and then kind of launch into the specifics of the initiative that I started with CHI-PAP. Broadly, the learning objectives are to kind of describe the barriers that would exist at each phase of care if you're looking to provide kind of comprehensive sleep apnea management for patients with low resources. And that includes then imagining within your practice environments, what would the processes that would be necessary to undertake that, as well as what some resources, including partner organizations and supplies, et cetera, otherwise that might be available to make that happen. So let's talk let's start by talking about sleep disparities across the lifespan. Unfortunately, we know that sleep disparities start early. So studies looking at infants actually show that total sleep is decreased in non-white infants, and actually sleep consolidation polysomnographically is decreased in low socioeconomic status Black and Latinx infants. Similar impairments have also been seen in low socioeconomic status young, school-aged, and adolescent children, and this includes decreased total sleep duration, as well as later sleep timing and higher rates of OSA as well. This is compounded by the fact that these kids are actually also less likely to be referred for optimal treatment as well. There's also a significant component in pediatrics in particular associated with what's called neighborhood disadvantage. We'll go into that in a little bit more detail in a bit here. In adults, socioeconomic status is maybe a little bit less clear, but there are clear racial disparities that exist. And what we've seen in multiple studies is that low socioeconomic status and non-white background are associated with decreased sleep duration in adults. From a PSG standpoint, an actigraphy standpoint, what we've also seen is that there's decreased sleep efficiency, higher fragmentation, as well as decreased amounts of deep sleep with N3 and REM kind of taking hits in non-white groups. This has been suggested to be associated with higher rates of shift work within these populations, so dysregulation of the sleep cycle in general that may then lead to these downstream sleep disparities. When we talk about racial disparities with regard to OSA specifically, what we see is from some of the largest cohort studies available that OSA syndrome, meaning symptomatic OSA, is higher and more prevalent in non-white populations. So you can see here from the MESA study, which is the multi-ethnic study of atherosclerosis. Large cohort study that 10 years on did 2,261 sleep studies in patients who had initially enrolled in the study and found higher rates of OSA in these patients, specifically symptomatic, meaning with excessive daytime sleepiness. A similar cohort was done in a Hispanic population. This was called the Hispanic Community Health Study / Study of Latinos, so HCHS-SOL. And this found that moderate or severe sleep apnea was present in 14% of these patients, with only 1% of them actually having received a diagnosis of OSA or recommendation for treatment. A similar type of study was done in Black individuals, and this was the Jackson Heart Study done in 3 counties within Jackson, Mississippi. And that found similarly that moderate to severe sleep apnea was present in about a quarter of patients, with only 5%. So a paltry representation of those patients actually recommended treatments or told about that diagnosis. What the MESA study that we discussed briefly before also found was that the Epworth, so the assessment for sleepiness, was also higher in Black men and women compared to white counterparts. When we talk a little bit more about OSA, diagnosis is also a significant disparity with regards to kind of racial and socioeconomic breakdowns. Studies have found that there's delayed recognition. This may be due to suboptimal screening tools. So the NOSAS, the Stop Bang, even the Berlin actually don't perform as well in these populations. And so you have groups out of Brigham and Women's and I can't remember where the doc who did the study from the HCHS-SOL study is from, but ultimately found that they could make models that better predicted OSA within those specific populations of Black patients and Latinx patients. This may partially have to do with different social norms or different perceptions of symptoms. So for instance, there may be kind of more of a perception that snoring isn't really something that requires medical attention necessarily, and that may be one reason. But then if patients get referred, get screened, I should say, there are still implicit biases that may play a role in terms of then referral for further workup. And so this is potentially due to issues with lower follow through if they're given a sleep medicine referral. This has been borne out in at least one study. And then there's another study in pediatric ENT done with pediatric ENT providers, which found that they were less likely to actually refer pediatrics with suspected OSA because of higher perceived burden associated with completing paperwork and navigating government assistance programs, which is really a shame. There are also socioeconomic considerations. Multiple studies mention that there's a higher perceived burden of treatment, as well as generalized mistrust in the medical system, much of it founded. And then, as a pulmonologist, I feel compelled to mention that with OSA being so dependent on oximetry data, there's this idea of occult hypoxemia and underestimation of hypoxemia in patients with darker skin tone. So standard oximeters have a 3-fold higher odds of missing hypoxemia in black or darker skinned individuals compared to white counterparts. And this certainly raises concern when you're talking about 3% hypopnea scoring, for instance, right? And you need to achieve that drop, or 4% for that matter. And ultimately, what this could do then is underestimate the severity of OSA in patients with darker skin. Shifting a little bit to this idea of neighborhood breakdown and how this may play a role in sleep disparities, I want to point out kind of this map of Chicago that gets invoked a lot. And Chicago is really an excellent example. I mean, it's kind of shameful, but an excellent example to point out what historical redlining practices have done in terms of kind of systematic racial segregation. On the left, what you can see is a breakdown of racial demographics in Chicago, with red dots representing white individuals, green representing Latinx individuals, and then blue representing Black individuals. And if you look to the right, then this is a completely different map. Okay, but this is a map from the University of Illinois Chicago, which has a very strong public health program. And what they did was compile a map of vulnerability index within Chicago. And that included percent of poverty, percent of people with less than a high school education, percent female headed households, as well as mean household income and employment ratio. And what you can see is that those maps overlap really strikingly, right? And that is very true then for a lot of health disparities as well. So when we look at actual CPAP use data, this was from a very large cohort, or not a cohort, I should say. It's actually a large data study looking at the Philips Respironics Encore remote monitoring database from 2015 to 2018. And they took all of the CPAP data and matched it with zip code data to find out who was using their CPAP more versus less, and they matched it with demographic data that was paired from the census. And what they found was that between the lowest and the highest income zip codes, there was a 40 to 47% difference, right? So 7% absolute difference between those two kind of geographic localizations. You also see that there's a total decrease in the amount of time that CPAP is used nightly, with 22 minutes less at 90 days of follow-up for patients who are living in high percent Black areas versus minimal percent Black areas. Actually, the exact same decrease when you analyze the data for Latinx neighborhoods, so over 25% and less than 1%. Again, for both of these populations, the suggestion made by the authors is that perhaps this has to do with interrupted sleep schedules because of environmental issues and or because of shift work. Also, they mentioned that there may be an interplay because of kind of harsh reimbursement practices where devices are removed from patients' households if they don't meet the adherence criteria within that first 90 days. There's also evidence that patients who have lower socioeconomic status also have decreased CPAP adherence based on the CMS criteria, with absolute decrease in adherence of 1.2% for patients living in neighborhoods that have high poverty rates, so over 25% of households below the poverty line, versus neighborhoods with less than 5% of households below the poverty line. And so to give you a kind of a pictographic demonstration of this, this is a Google Earth representation of South Halsted Street. And I picked it because I actually live on North Halsted Street, and it is quite striking the difference between. And so if you look here, you can imagine multiple things that may negatively impact sleep. So first off, light pollution that would decrease melatonin secretion and dysregulate sleep patterns. Noise pollution, which of course could lead to sleep fragmentation. Air pollution, which has been shown to increase the risk of OSA due to airway inflammation. Decreased walkability that may increase rates of obesity and weight gain. And then finally, asphalt and heat island effect, especially during the summer, that has also been shown to negatively impact sleep. And so when you think about kind of the reality of some of these neighborhoods and how they're not structured well for adequate sleep, it kind of hits you in the face, right? And it becomes kind of striking the ways in which our built environment very much contributes to sleep health. And so pivoting then a little bit, I want to bring you back to the pandemic, because that was really the impetus for starting the free clinic through CHI-PAP. And the idea here was really that the pandemic laid bare a lot of disparities, right? In the same way that kind of looking at that picture of a kind of barren urban landscape can kind of give you a striking picture of why these disparities exist. I'll take you back to late 2019, early 2020, when those of us on the front lines, and I'm sure many of you in the audience here today, also worked in the ICU during this time. And I remember seeing really right in front of me play out all of these horrible disparities where we had whole families, oftentimes Latinx or Black, admitted at one time. I remember one case where there was one son who was 18 years old, the only one who was remaining at home, where mom, dad, sister, and brother were all in the hospital intubated. And this, weighed heavy on a lot of us, right? And it was a lot to take. And of course, then this was compounded by the murder of George Floyd in May 2020, that then kind of spurred this big social justice movement, which unfortunately seems to maybe have backslid a little bit, based on where we are socially currently. But nevertheless, the first thing that I did, because I was so distraught with what I was seeing, was I wrote an op-ed for the Chicago Sun-Times. I'm speaking to some of these disparities that were laid bare in front of us. And I really include this solely to maybe inspire some of you out there who feel uneasy with what you're seeing in front of you. And just to say, it's easy to paint ourselves into a place of feeling like we can't make a difference. But what I would argue is, especially coming from a place like Yale, your opinions as a physician are really going to hold more water than you think they might, right? And the chances that someone would listen and publish, your opinions are non-zero. So at the time, I found myself in a very bad headspace, and this was around the Delta surge, so the winter of 2020. And I remember talking to my now ex-husband, but at that time, just really lamenting about what I was seeing. And he kind of callously said, yeah, but what are you doing about it? And, after I got over the hurt feelings, I think it, kind of really was maybe the right question, because it got me thinking back to what really inspired me to go into medicine in the first place, and maybe made me think about, when did I last feel particularly fulfilled along those lines? And it harkened back to a time when I was in medical school many moons ago, when I volunteered at Community Health on Chicago's Near West Side. And made me reach out to them. And when I reached out, I said, hey, I graduated from pulmonary critical care training. I am about to graduate from sleep training, that was in 2020. And I said, I could provide pulmonary, I could provide sleep. What do you need? And they said, absolutely, unequivocally, we need sleep. They said at Community Health, it was a 10-month wait time to get somebody in for an external sleep study at Cook County, which is our county hospital, also now called Stroger. Ultimately, what they said was that even if somebody got in for their sleep study, there was no guarantee that they would be plugged in to get a machine. Even if they got a machine, they were kind of sent back to Community Health, and then Community Health lacked the ability to then, manage the device, give them supply refills, and to check in therapeutically and see whether they were actually benefiting from the CPAP. And so at that point, interestingly, I think that they would have, I think their ask initially was that I would have been a conduit into Northwestern's sleep lab, which I said, absolutely, we'll make that happen, no doubt. But I said, we should really dream bigger, because at the end of the day, the majority of our sleep studies are done in the home setting. And, we do a disservice to our patients by not trying to figure this out. So this, though, then led to this idea that, the big elephant in the room is ultimately that requires technology, right? That requires certain resources. And it harkens back to this idea that sleep care in general is heavily reliant on access to technology and medical equipment. And traditionally, it's been really difficult to start and maintain uninsured patients on CPAP. And I should say that the majority of patients at Community Health are uninsured, many of whom may be undocumented as well. So they kind of fall through the cracks, even when you're talking about things like Medicaid. This then led me to kind of a thought experiment where I just did a quick systems walk. And I thought, well, okay, what do we generally need, soup to nuts, to get somebody retained in care for OSA management? And of course, it starts with an evaluation, right? So the patient comes in, they're seen for their issue of snoring, excessive daytime sleepiness, whatever it may be, AFib. The evaluation then leads to sleep testing, if appropriate, right? And you get them set up either with an in-lab or a home study. You then, if they test positive, get them connected with a durable medical equipment company. And the durable medical equipment company will get them the supplies and device, and hopefully then they start using it, and they're followed up ultimately to document compliance or adherence and benefit, right, long term. Unfortunately, the overarching piece here is that in the U.S. healthcare system, none of this happens without Scrooge McDuck, right? Somebody trying to kind of make money every step of the way. So what this means for our patients then, especially our low resource patients, is that if you don't have insurance, you don't get the evaluation or the sleep study. Without insurance, without the study, you don't get connected to a DME. Without the DME, you don't get CPAP equipment, supplies, or equipment servicing. And what this means then de facto is that many patients then are siloed completely outside of care. So, this didn't sit well with me. And it got me thinking, well, how might I fix it? Right. And so, based on that systems walk, it made me think about kind of a four-pronged or four-phased approach where the first step would have to be triage and referral. Then you'd go into diagnostic testing. If they tested positive, then you'd aim to have PAP initiation. And then finally, you would aim to follow them up long term and retain them in care and document benefit as they go forward. So it led to the next question, which was essentially, well, what would I need then to get started? First and foremost, I needed subject matter expertise, but that was relatively easy. That was happening as part of my sleep training at the time, right? I was learning how to provide care across that spectrum from beginning to retention of care in the patients that I was seeing at Northwestern. I knew I was going to have to cross-sectional plan, right? And that's because I couldn't do this alone. It wasn't going to be an easy lift. And so there would have to be, not only community health, but then leveraging other, stakeholders and partners in this endeavor. And then ultimately, this led to the additional process of process and resource mapping, where in a really specific way, and we'll go into the details of this in a second, I kind of laid out for each of these phases what would be necessary in terms of processes and resources for each step of the way. Usually if I'm in person, I ask, who this is, and I throw a tote bag to somebody who gets it right. But since we're not in that kind of an environment, this is Quincy Jones, rest in peace. I think he passed over the past year. But Quincy Jones used to have this phrase, no paralysis by analysis. And I really love it. And I kind of harken back to it a lot because what it reminds me is you really can't let your initial analysis stall you out, which is super important when we're talking about things like quality improvement and health equity initiatives. This can be a really tough idea to wrap your head around when you are medically trained. I think many of us want to aim for things that look a lot like an RCT and are as controlled for possible confounders as possible. But at the end of the day, that really might not be feasible nor advisable, right? And so the message with no paralysis by analysis is like, hey, get started, right? Think big, think strategically, be smart about it, but ultimately get going. And it also reminds me to kind of give credit for movement from zero to non-zero, right? This idea that we have patients, like before we started, patients were completely siloed outside of care, had no means of getting treatment for their OSA. So if it meant that, the way that we were able to treat them was just getting them the sleep study, but maybe we didn't have the devices yet, well, hey, that was something, and that was above and beyond what they were previously getting. Right. And then eventually, once we got devices that maybe were less, up to date than, the AirSense 11, for instance, right? From that standpoint, to have a functional older device, better than nothing, right? Fortunately, in Illinois, we have very favorable laws to allow for this. This is actually a snippet from the Illinois General Assembly, the actual laws on the books, which states that if you are a licensed healthcare professional and you're providing good faith medical treatment, diagnosis, or advice as part of services rendered through an established free clinic, that as long as you are not, wantonly wantonly negligent or willfully negligent, that you are essentially covered, and that in providing this care, you are not going to be liable for possible civil damages that may come from this. So this then laid the groundwork where I was able to establish this four-phase CHI-PAP protocol. CHI-PAP being a play on BiPAP, but standing for Community Health Initiative for Patient-Centered Apnea Protocols. So the overarching idea of CHI-PAP was to remove the insurance company, right? Because we just didn't have them, right, for these undocumented, uninsured patients. To remove the DME company because they weren't going to play ball without, the insurance company paying them, and then to leave only the essentials. So this led to the four-phase approach where phase one is referral and initial evaluation. phase 2 diagnostic testing, phase 3 CPAP initiation, and phase 4 longitudinal follow-up. For each of these phases then, I went and did a granular analysis, and this involved looking at the available resources for each of the phases, each of the processes that would be necessary for attaining the desired outcomes, as well as anticipated challenges and barriers, and finally, looking at short-term and long-term outcomes for each of the phases as well, to kind of know whether we were, making movement in the right way for each of them. The data collection method that I chose to use, because I am not a statistician, nor do I, want to be, is something called a run chart. And for anybody who has not been enlightened to this before, it's a really nice, relatively easy way to semi-statistically know whether the data that you're collecting quickly, and you can collect a lot of data in multiple, multiple different metrics at the same time, chart them all independently, overlay them, and you can look at these trends to see, are you getting non-random, non-random chance changes? So this is, by means of looking for different patterns, things called shifts, or specifically trends, which means something specific in terms of the run chart or number of runs of your data as you're going along. And so again, this can be a very powerful way to actually make sense of what you're doing without needing a lot of, statistical computing power. So let's go kind of phase by phase, and I'll just briefly talk you through how each one of these things was laid out. This is very much predicated on a QI mindset, wherein we're really identifying process measures as well as balancing measures, and then trying to identify ahead of time solutions that may be available for counteracting those balancing measures. So, for instance, to start with, for referral and initial evaluation, ideally the provider at community health, and I should mention also that community health is a really unique institution in that it's a free clinic, but it really prides itself on being a medical home for people, meaning that they see the same provider when they come back, and they actually bring specialty care to patients. So they have cardiology, neurology, rheumatology. They actually have a hand surgeon who comes and does carpal tunnel surgery for them in-house. So really remarkable what they aim to do. But the whole idea here is that they have dedicated providers who know these patients. And so these providers then, the primary care providers, for instance, or if it was a neurology provider or the pulmonary provider, if they identify that they have evidence of sleep apnea, they place a referral. Of course, the anticipated challenge, the possible balancing measure here would be that, there might be non-indicated referrals, there may be excessive referrals, but luckily we have this organized clinic structure where there are huddles before each clinic starts. And so if this was going to be the case, well, we would be able to actually intervene and say, hey, don't refer for X, Y, or Z indication. We really want snoring. We want excessive daytime sleepiness, insomnia initially, et cetera. Ultimately, when the referral was placed, I would review it. The concern was that there was going to be an excessive volume, but we had this dedicated balancing measure where we would be looking for what was the quantity of referrals that we were getting on a weekly basis, and just making sure that it was manageable. If deemed appropriate, that referral was then turned into the initial visits, and they were triaged, right? And so if I got the sense looking at their chart that, hey, they might need a higher level of care, well, fortunately, we actually still had that conduit into Stroger for escalated levels of care that maybe the clinic wouldn't be as able to provide, especially early on while we were figuring things out. We were worried initially about potential long wait times. That actually became the reality later on, which I'll show you. But ultimately, again, we had a metric built into place so that we could monitor this and ultimately intervene when it was becoming a problem. So in terms of our outcome measures for phase 1, we were looking at the percent of patients with sleep-related concerns who ultimately were referred for external evaluation. So the idea here being that we started with 100%, right? 100% of patients initially before the clinic were being kind of shunted to the safety net hospital. So I set a modest goal of a 50% reduction over the first year. When we absolutely met that, we actually did not have to refer anybody out during that first year of the clinic. That's yours truly with slightly different hair back probably 2 years ago, seeing a patient during the clinic. For phase 2, diagnostic testing, the first process here was that patients warranting testing would be assessed for appropriateness for a home study rather than in an inpatient study. My concern was that we were still going to have a certain number of patients who needed an in-lab dedicated sleep study. But ultimately, this actually ended up being much lower than maybe I had feared. But we had nevertheless maintained the connection to Stroger, so the safety net hospital, as well as Northwestern's sleep lab. Patients who were greenlit for a home sleep study then were set up with a CHI-PAP device. And specifically, the device that I chose to use was the CHI-PAP 200 because it's a reusable home sleep testing device, which is relatively easy to use. It has minimal straps and things that you actually have to connect. It's like a probe on the finger, a strap on the wrist, and then a little stickum on the chest. The anticipated challenge with the CHI-PAP 200, though, like many of these home testing devices, is that it does have non-reusable components to it. And so ultimately, we were able to work with Itamar, the manufacturer, and they give us wholesale pricing for the non-reusable PAP probes, which is like the finger probe that costs about $50 a pop. When completed, these the HST data are uploaded by me into the interpretation software called CHI-PAP, and then a standard, basically reproducible. You can take this report to any health system, and it should be valid because it is an FDA-approved device. Is generated, and so. The concern with the CHI-PAPs ultimately and these HSTs was that sometimes those devices just don't work well. The battery goes dead, et cetera. So what we ended up doing was actually getting a fleet of these devices over time. So I think we've probably got about 5 that we're able to cycle out if one has gone down. And I have actually figured out how to solder and replace batteries, gotten really technical, to try to extend the life of these things as much as possible. For those that have really severe disease, there was a process that was built in so that we could then refer to a higher level of care, whether it be at Northwestern or Stroger. Fortunately, because of the donations that we ended up receiving, we ended up with higher level devices. So RADs, respiratory assist devices, BiPAP devices, essentially, that I have been able to use for some of these patients who actually do hypoventilate. And so from that standpoint, we actually have not had to utilize that pathway nearly as much as we maybe necessarily initially thought. So the outcome measure for phase 2 was the average wait time from the initial evaluation to the completion of the diagnostic study. The specific aim in this case was a 50% reduction. So, starting from 10 months for that wait period when I had initially reached out to community health, aiming to bring it down to 5 months over the first year. And ultimately, we were able to achieve this. The average wait time is actually under 2 months at this point, and that's actually held pretty steady. So this is what it looks like when interpreting these devices. So you can actually see the device in my hand. It connects through a USB, a micro USB hookup, and is then uploaded into the CHI-PAP software. Phase 3, CPAP initiation, starts with those patients testing positive for OSA being given a refurbished CPAP device. The anticipated challenge here was real initially. What we had at the very start was relatively old devices, old REM stars from Philips, old F&P devices. Fisher and Paykel does not even make CPAP devices as far as I can tell anymore. And we had some old S9s as well from ResMed. But nevertheless, again, it was something. And we vetted these devices, ran them on a test lung, made sure that everything looked okay. And those were the first devices that we dispersed. But there was always this sneaking fear in the back of my mind that we wouldn't have enough and that we would leave patients in the lurch, waiting a long time after they had tested positive. Fortunately, victim of our own success, these donation drives that we've had through Northwestern and through the website, and thank you to the AASM because I was able to give a presentation similar to this that I'm sure then spurred more donations. My cup runneth over and my basement is full of CPAPs is a joke that I've made before, and it is very true. My office is also a mess, has lots of CPAPs and lots of filters and supplies. Along those lines, patients are also set up with unused, donated mask interfaces, tubing, filters, et cetera. This is actually something that still kind of keeps me up at night. we have certain things in abundance and other things not so much. And I always worry that we're going to get somebody who's super comfortable on a certain mask and then not be able to provide a refill for it. And that is what it is. We do, though, have an ample amount of masks. It just might not be necessarily the mask of their choosing, but we do have things like chin straps. And so we can get creative and try to make things work within the confines of our limitations. So finally, patients are given an SD card for long-term data monitoring within their device. The problem here being that while many of these devices have some kind of an online remote platform, AirView for ResMed, Luna, I think, has their own, or at least is going to be launching their own soon. Philips had their own Encore. Those actually cost money. And so, we didn't necessarily have the resources to, get into that. And so instead, what we opted for was, hey, please bring your device to each visit, and we're going to actually do a direct interrogation and look at the data, the residual AHI, the nights of use, time of use, et cetera. For our outcome measure for phase 3, it was the percent of patients meeting criteria for PAP initiation, so testing positive essentially on the HST, that were started on CPAP within 2 months of the positive HST result. And I wanted to get 75% of these patients within the first year started. And I believe at 12 months, it was actually at about 80%. So we did meet that initial aim. We've hovered probably around 75 more in the longitudinal, since that first year, but nevertheless are right around that specific aim. This is actually a picture of our very first patient that we had started. You can see her using donated S9 with nice heated tubing, and not the cutest mask, but it works, right? And she actually is still retained in care and doing very well. And to the point earlier, we started with these older devices. And, as soon as she told me, hey, I think this machine's on the fritz, I said, hey, you're in luck because now we actually have newer, better devices. So come in, we'll swap it out. And so I got her, I think, set up with an AirSense 10. But all to say that this has been a very dynamic process, and we're always looking to improve what we're able to provide the patients with. And I should mention also, this was, the patient knows that this picture was taken, full agreement to be included in the presentation. And then finally, phase 4. So for longitudinal follow-up, ultimately, we schedule them for 3 months for that initial follow-up visit, kind of within what they would get standard of care if they were trying to meet CMS adherence guidelines. And the concern was that this was going to, lead to high volumes for those requested follow-up visits. But we had some flexibility built into our clinic schedule so that if they needed an additional short order follow-up, there were kind of added in flex spots that wouldn't necessarily be filled that we could then offer patients if they were in need. And then finally, once patients demonstrated that they were retained in care, they were doing well, at that first 3 months, or if they needed an additional and it was 6 months follow-up, then ultimately we would extend that out to a year and set up a pathway where they could talk to clinic staff or go through the website to request refill masks, tubing, et cetera. In terms of our outcome measures for phase 4, we were looking at the percent of patients meeting CMS PAP adherence criteria, and the aim was 50% at 12 months. And ultimately, we had low numbers at 12 months. That was, because we probably had maybe like 4 or 5 patients who had gone through that entire process and had reached that first 3-month follow-up, for instance. But it was just above 50%. I think it was 60% at 12 months. Since then, we are hovering at about 70% of patients that have actually met adherence criteria after starting, and specifically not saying, hey, I hate it, please take the machine back, because there have been a few of those. But those who have benefited from therapy and who have continued have actually done very, very well. So I want to speak briefly about some of the innovation that we do at CHI-PAP. So first and foremost, I just want to point out, this is a real snippet from eBay previously for one of these WatchPat devices. And it's just to show that, it's $600, it's not nothing. But when I actually started this clinic, I did a moonlighting shift in our ICU and took some of that money and used it to buy our very first home testing device. All of that is to say that $600, while not cheap, is also not all that expensive for medical grade equipment and technology, especially something that's actually going to be reusable. This one, for instance, actually came with a box of 12 PAP probes. So added benefit there because you're actually saving on some of the non-reusables. And my argument is that this is a fundraisable amount of money, right? So if you were looking to do an initiative like this is something that realistically could be done. I also like to think that what we are doing is upcycling devices. We are prolonging their lifespan, just delaying that transition into the landfill. I mean, unfortunately, these will end up as e-waste, eventually, but we are very much extending that life to, basically its maximum, and allowing patients to get the maximum benefit out of devices that otherwise would have sat in somebody's closet or just gone to a landfill, even though they only had 1,000 hours of use, right? Within a 10,000 hour motor life. And along those lines as well, the piles of filters and mask cushions, et cetera, that I have, those are from patients who never use them. Maybe they got re-upped for, mask cushions that they didn't need because DMEs make money every time they disperse. So from that standpoint, we are absolutely decongesting the landfills, at least temporarily, and repurposing these materials for what they were intended for, rather than just skipping right to the waste bin. And then finally, I just want to mention that I developed a way to 3D print CPAP masks that are actually molded to patients' faces. I maintain that I think this is a great idea. I think it will actually, hopefully work at some point. But in the way that Illinois was actually very favorable from a legal standpoint for providing free care, it actually is horribly prohibitive from the standpoint of biometric data storage. And so I did not want to have to get into trouble from storing scanned faces, because essentially what I would do is LiDAR scan somebody's face, you mold the digital mask to the patient's face, and then you 3D print it, and it prints out with the mold of their face. So you minimize leaks is the whole idea. So more to come on that, but that's another form of innovation, that kind of came about because of the clinic. So by the numbers, we started seeing patients in October 2021. And remember that I said I reached out to them in the winter of 2020, just to say that this took a year of planning before we actually ever saw the first patient in the clinic. Since that time, and this was largely myself, 2 Saturdays per month, I would see patients. We've since had another provider come on. My mentor, Haraya Rotarian at Northwestern, has picked up a few shifts. We'll be there once a month or twice a month sometimes. But to a large extent, these numbers are from the first few years when it was myself, 2 Saturdays per month. So we've had 241 unique sleep disordered breathing visits over that period, 92 unique patients tested with home sleep testing, and 8 patients currently on the wait list. There were some patients who had to repeat studies because of malfunction of the device. So I think total we've done about 100 actual unique WatchPad studies. We had 54 patients so far who have started on CPAP. And then we previously were seeing patients in a dedicated insomnia clinic. So it would be 1 Saturday per month would be insomnia, 1 Saturday per month would be sleep disordered breathing. And there was always some kind of bleed over between the two. But ultimately, the need for sleep disordered breathing kind of overtook the insomnia piece. Not to say that insomnia care is not important, it absolutely is. But so we ended up kind of shunting those patients into a pathway of app-based cognitive behavioral therapy for insomnia as a way to kind of diffuse the need and better address the need, I should say, for sleep disordered breathing evaluations. We've had a total of 104 new patient visits and 180 follow-up visits in total. Looking at the run chart for the sleep clinic wait times, if you look at the left side of the screen, what you'll see is that in red, that is the wait time at the safety net hospital. And in blue is the CHI-PAP wait list. Victim of our own success. As we went along and word of mouth spread that we had this resource, referrals really did tick up. And what that meant was that we had rising wait times. And as of, I guess it was December of 2023, it actually was on par and then exceeded the wait time at the safety net hospital. I think the other thing to point out on this graph is that early on, we actually very much diffused and decongested the wait list at the safety net hospital. As we started seeing people, basically the wait times came down, probably because we were no longer adding patients to that list. And I think that's the benefit, right, in terms of the social impact of this. We are unstressing the safety net with this type of initiative. And as you can see, starting in March of 2024, so we had been at a higher wait time compared to the safety net hospital. That's when Dr. Atarian started seeing some patients in the clinic. And since adding that second provider, we've been able to come down, at least we're on par now for wait times compared to the safety net hospital. And my argument is still that we provide comprehensive care within those four walls of community health where they are already retained in care. And so I think, we have that added benefit for them. In terms of, excuse me, in terms of our cohorts of CPAP patients, ultimately they are patients with a high burden of disease. The average or mean AHI is 31.1 in the interquartile range in terms of the median. That goes from high moderate over to very severe. They have lots of hypoxemia, mean of 33 minutes. And then the Epworth is also high, suggesting that these are symptomatic patients who are probably really going to benefit from treatments. If we look at the time to sleep testing, what we see is that the median wait time for our patients is about a month. And that's not too bad, all things considered. And interquartile range is 7 to 56 days. So, at kind of worst, they're waiting about 2 months. In terms of time from CPAP initiation to that first follow-up, also, you can see that the average is 53 days. And the interquartile range actually falls exactly where you would want it from a CMS standpoint. So we're not, beholden to CMS criteria, but all the same, I feel like we're actually providing standard of care because we are getting patients in within that time frame. I'd like to kind of start to wrap up here with a vignette. I had a patient, middle-aged Latinx gentleman who came in and was incredibly symptomatic, like literally falling asleep in front of my face, as I was talking to him. And I think we've all seen patients like this in our clinics, and was just really miserable. So we got him set up with a watch pad, and this is what it looked like. And for those of you who may not be familiar with this readout, up top, every little blue bar is a respiratory event. And in orange, you see snoring, and in black, you see, in that third box, you see the SpO2 tracing. And that is consistent, in my eyes at least, with hypoventilation, right? Deep desaturations that last, right? They don't just spring back up. And so I was worried about this guy. So we had scheduled him for the follow-up in short order, and then he no-showed. And I remember asking the clinic coordinator, hey, can you call him? Like, I really want to make sure we get him connected. And he said when they called, he's like, hey, I'm so sorry I missed the appointment, but I haven't found work recently, and I just got offered an odd job, but it's on Saturdays. And that's the only time I was there. Right. But I said, hey, when can he come in? He was able to come in the following Monday afternoon. So I hightailed it over there after finishing my clinical duties at Northwestern and saw him. And I'll never forget it. I started him on a BiPAP machine because of this concern for hypoventilation. And as soon as, he put it on, he just melts into the chair and kind of nods off. And I like gently wake him up. I'm like, hey, how are you feeling? And he kind of gives me what I call the reverse Levine sign, the Levine sign being like a sign of ACS. And he goes, man, my chest, it feels lighter. And I'm like, beautiful. Like, you're going to do great. You are the reason we're doing this type of care. He is the example of, the disproportionate benefit that we can do to our patients when we provide them the care that they were otherwise, kind of excluded from. In terms of other ripple effects societally, there's a Scandinavian study that actually looks at motor vehicle accident risk associated with OSA, and it shows that if you use CPAP, that risk goes down. Their analysis showed went from 7.6 to 2.5 accidents per 1,000 drivers per year, statistically significant. My argument is, hey, that's a very different population. I think ours is more severe. I bet the risk reduction actually might be a little bit more profound, potentially. But even in their study, the number needed to treat was 196 patients. And, from my standpoint, we're 54 patients on CPAP at this point. We're getting there, right? So this then maybe, begs the question for those of you listening who may be inclined to do something similar, whether it's with sleep care or, if you want to tackle your another type of health disparity, within your realm of practice. I think one thing that you need is a really good partner organization. I was really fortunate to know that community health was the type of place that had resources and infrastructure so they could handle the scheduling and, some of this kind of overhead of running this type of clinic, but also be willing to kind of see my vision and trust me and let us hit the ground running and support us along the way. I think realistically, you need a large metro area with a sufficient donor base if you're going to go off of donations like we do. And so along those lines, there's no reason to believe that that New Haven, and the kind of surrounding area, especially because it's adjacent to New York City, couldn't fit the bill. And then, of course, to start, you need some kind of funds or fundraising to get things off the ground. For me, I put some money, you know, into the initial effort because I just felt strongly about it. When I don't have kids, like it was not a financial hardship for me, and I wanted to see it work, right? But ultimately, I also applied for an AASM foundation grant, a community engagement grant that supplied us with close to $20,000 of seed funding. And so incredibly thankful to them for having, kind of seen the promise in this, because it was absolutely necessary. And now that we're off the ground, it's kind of self-sustaining, but oftentimes you may need to explore those types of resources. And then finally, I don't take lightly the fact that this is a really heavy lift, right? And especially because I've done it on my own for a long time, recently got some extra providers on board, and certainly had the clinic staff behind me and colleagues and, people who were kind of ancillarily supporting. But nevertheless, I took it very seriously that this was a big time commitment from my standpoint, and that if I was going to start to do this, this was not going to be a do it for a few months and then ghost type of a situation. And so, even after I'm in the ICU, so last week, for instance, I was in the ICU and we do Saturday through Friday. And so I'll end on a Friday in the ICU, and then the next morning, a Saturday, be going to the free clinic. And on the way there, I'm always like, oh man, why did I sign up for this? But I get there and it always fills my cup. Right. And it just reminds me, like, yeah, no, this is what I actually want to be doing. And again, it's one of the most impactful things that I've done. And so these types of longitudinal commitments are worthwhile. But if you're going to undertake something like this, just be aware that, hey, you should be in it to win it. Because if the partner organization is going to be, really supporting you and putting their neck out for you, you want to make sure that you are kind of reciprocating. So big thank you to the AASM Foundation, Northwestern Medicine, all of my colleagues here, as well as Cook County Health, for the ways in which they've supported this initiative kind of since its inception. Please, anybody interested, please take a look at the website that I made for the organization as well, just more information. If you have anybody that you're talking to in clinic who wants to donate their machine and they're willing to pay a few bucks to ship it, we'd be happy to take it. And CHI-PAP.org is the website. Got a little bit of swag there if anybody's interested. And I want to leave you with this just unifying thought, which is health equity could be a unifying idea if we see opportunities for good health and well-being as a basic right for all. We see poor health of disadvantaged and marginalized populations as an indictment of an unequal society. But we also recognize that focused initiatives can make a difference. And we ultimately acknowledge that by coming together to address the social determinants that underlie health inequities, we will also address the roots of other social problems, meaning that by addressing inequities in our small ways that we can, we really do end up improving society as a whole. So references for anybody who's interested, and acknowledgements to everybody at Community Health, my mentors at Northwestern, as well as everybody who's donated supplies thus far. And with that, I'm happy to take any questions. Thank you so much for the invitation and for your time.
Excellent. Thank you so much, Dr. Fiala. This is such a fantastic talk, and for sharing this amazing, challenging, and inspiring work that you've been doing. With this, I'll open the stage here for question. Looks like I have one question from Dr. Karen Johnson. Now that you can search for devices by serial number on AirView, do you find that some donated devices are still transmitting data that you can use?
So the problem is, and the reason that I actually don't even go that route anymore is because I have not figured out a way to succinctly unlink that serial number with the initial patient. And so I don't even want to be involved in like any HIPAA violation therein. And so all I do is I just erase the data from the machine, put a new SD card in, and I just directly interrogate the device so as to not, open up that bag of worms. But excellent question. Yes, I think they actually would continue to potentially transmit the data.
Great, thank you. This is from Dr. Lauren Tobias. Thanks so much for the wonderful talk, and you're doing an amazing work. I second that. And I don't have any other question. Just a question that I had, the thing that you're doing is definitely very challenging. And like you said, it's a huge financial as well as time commitment. For any folks that's interested in doing this, maybe what are your few most important, tips or suggestions that, the first line that you would say that, okay, this is something that's really important, that's really needed to do, besides all the things that you discussed about from your experience. And then the other question I had was, have you been able to do in-lab study for complex patients, or is that something on your horizon?
Yeah. So I think one of the tips is start with what you have at your institution, within your own patients, even, and the patients that your colleagues are seeing. Again, what really shocked me is just how much waste there is in the system. Supplies that are dispensed without patients needing new supplies, machines, for instance, that patients are just like, yeah, no, I haven't used it for 5 years, but it's just sitting in my closet. And you might find that there's actually a wealth of resources there that could be enough to start, right? Because again, we started with very little. Community health had previously told people, don't donate your CPAP devices because they didn't have an outlet for them, but they did have a few. And so we started with a few very old devices that they had previously gotten donated. And then, from clinic patients, it's just been an easy way where, like, when you are re-upping them, right, because they're going to want the newest device, or they're going to be due for one eventually. It's just an easy conduit to say, like, hey, do you want to donate? And if you're working with an organization that is pre-established, community health actually gives out tax donation letters as well. So if they're interested in that, it's kind of a win-win. They get rid of the junk, or what they perceive as junk, and they could potentially use it as a tax write-off, if they're also donating other things to get to that threshold. And then to answer your question, Dr. Thapa, about the in-lab studies, yes, we've done, I think, two in-lab studies for patients who were just like, either we couldn't get readings on the watch pads, AFib or whatever the case was. And then I think someone else who I was just concerned there was something else going on. And what we wanted was like an extended EEG, because there was concern for like maybe seizure activity based on like history. But yes, I mean, and I think the nice thing is when we've had those requests, they actually go through relatively quickly, because otherwise we're taking care of our own in-house.
And how do they pay, or how do you manage that?
Yep. So Cook County has its own process for that, which is already like well established. They just go through the same steps that they previously did to get those patients in, and it does require kind of documentation of income or lack thereof. And similarly for Northwestern, there is a charity care quote unquote pathway that they utilize for these patients.
And I guess it also depends on the state. If, like you said, Chicago does not have the legal, binds, but if the states, they have these legal binds, what do you do in those situations too?
Yeah, that's tough. And I had previously worked with two folks from Texas who were looking to do this, one in Texas and I think one in Dallas. Sorry, one in Houston and one in Dallas. And they said, they're like, yeah, no, actually, like, we really can't. And they couldn't do it out of their primary practice location because there was like a conflict of interest, essentially. Because that was a revenue generating practice, you couldn't then go and do free care. So again, that's where I think actually the partner organization becomes incredibly important, because if there's going to be a law like that on the books, it de facto kind of has to be within that organization. It kind of can't be tied directly to a revenue generating organization, at least as far as I understand it. And that was specifically the issue in Texas. They said like they couldn't hold the CPAPs, for instance, in the clinical location where those folks worked.
Yeah, I think it's the same here in Connecticut. I don't know if anybody else has any other thoughts on that. I don't see any other questions or hands raised, but this was excellent. Thank you so much for sharing your amazing work. It's such a wonderful human being. Thank you
No,
again.
thank you so much. No, really, I
Uh,
appreciate the invitation more than I can say.
yeah, no, and thank you everyone for joining. We'll see you next week.